The facts about A&E. In 2014, 14.6 million people were seen in A&E, an increase of 500,000 in a year, the equivalent workload of 7 A&E departments. And while that's a lot, the UK actually has the third lowest attendance rate of 11 comparable nations. More patients attend in the summer, but we admit more in the winter. Sunday is the busiest day of the week. While only 2% of our patients suffer from major trauma, heart attack or stroke, 75% of all hospital admissions come through the doors of A&E. So A&E doctors deal with a lot of people. The average number of A&E patients per consultant per year is over 10,000, and that has inevitable consequences for our patients' experiences. Despite this, junior doctors can't wait to work in A&E. They love their departments and their jobs, and we've expanded the number of entrants by nearly 200 in just 2 years. The problem comes later on, at registrar level. Half of all our registrars leave emergency medicine, either to a different discipline or even to a different country. We've spent over £250 million training more than 500 emergency medicine doctors who currently work in Australia. This trained brain drain means we've spent another £500 million on A&E locum doctors to backfill those we've lost in the last 3 years. We don't think this is a problem of poor salaries. When we ask emergency physicians why they're leaving, money doesn't even make the top 5. We need fairer, sustainable rotas, so staff get to spend as much time with their family and friends as colleagues who don't work in 24/7, 365 services. Although pay isn't an issue, money clearly is. Last year, of the £700 million of so-called winter pressure cash given to the NHS, the college's survey revealed that less than 10% ended up directly in A&E departments. The rest went to try and stop people attending A&E, or preventing more admissions, or speeding up delayed discharges from hospital. But attendances went up 500,000, admissions by 7%, and there was twice as many delayed discharges this winter than last. So if we want to avoid queues coming out of the door, patients dying in ambulances, and the negative headlines that follow, the college believes more winter pressure money needs to find its way directly into departments, and in time to cope. Some people say that our patients are the problem, that they use A&E too much for too little. We never blame the patients. It's true that 15% could have visited a GP, but A&E is a powerful brand. So we think, rather than spending money trying to stop people visiting A&E, we should co-locate out-of-hours primary care with A&E. And that's not just GPs, but community psychiatric services, pharmacies, dentistry, the lot. A&E should become the out-of-hours urgent care hub. For those patients who do need to be in A&E, it's vital that our departments aren't overcrowded. Where there's exit block, where patients need admission but are stuck waiting for a bed, all patients suffer, and for some, roughly 550 a year, it's fatal. The college estimate around 400 people die because they can't get into the hospital soon enough, and a further 150 because they were discharged home inappropriately. And to top it all, exit block is a vicious circle. We know that patients admitted from departments suffering exit block have longer stays in hospital, compounding the problem. The challenges facing A&E across the country are huge. It may seem complex, but the answers are straightforward. We need to tackle staffing and retention of expertise in the workforce, getting payment mechanisms right for hospitals, tackling exit block, and primary care co-location.